Rapporteur session. We have Yvonne Shaka with us. Okay, so I'll go ahead and start. Welcome to the closing ceremony of the 46th World Conference on Lung Health. Our theme this year has been the new agenda, and within the landscape of the Sustainable Development Goals and the launch of the Global Plan to End TB, I've been inspired to hear how we as a community will take up the fight of this new era. There are over 4,000 of us that have been here from 134 different countries and nearly 100 journalists, making this the largest ever world conference. At the start of the week, we welcomed nearly 50 parliamentarians from 30 countries at the TB Global Summit. We heard Minister Motsoaledi tell us all that any human being on this planet who has TB must have access to treatment. And the next day, TB Alliance and its partners announced the availability of the first child-friendly TB medicines. These medicines are dissolvable and flavored so that they are easy for children to take and simple for providers and parents to administer. In our Meet the Expert sessions, two of the world's leading HIV researchers, Professor Robin Wood, discussed the START trial, and Professor Stephen Lawn discussed systematic review in postmortem TB findings and the role of urine in TB diagnosis. And we stood to applaud the brave and inspiring testimonial from Juliet Vivian Nalumu at the inaugural session. Juliet is the site coordinator for Mothers to Mothers in Uganda, which offers support to women living with HIV. We are all moved and inspired by her story. Imbizo was a vibrant community space bringing together events, discussion, and learning open to all. The collaborative mural painting is one of my favorite moments at the conference. Treatment Action Campaign has played a key role in Imbizo and is widely acknowledged, as well as the March, and is widely acknowledged as one of the most important civil society organizations active on AIDS. TAC was largely responsible for bringing ART access to South Africa. And so I would now like to welcome to the stage Aneli Yawa, the General Secretary from Treatment Action Campaign.
Program Director, delegates, comrades and friends, receive my revolutionary greetings. Firstly, I thank you for the opportunity that you have afforded to us as TAC to address you in this august occasion. As the Program Director has said, I'm Aneli Yawa, and I am the General Secretary of Treatment Action Campaign in South Africa. As TAC, we have more than 8,000 members and 182 branches across the country. Our members are dependent on a struggling public healthcare system. Most of our members are the poorest of the poor. Here in South Africa, more than 80,000 people died of tuberculosis last year. More than 1.5 million people worldwide died of tuberculosis. The world is facing a TB emergency, and we have to declare it as such. Every year, we get only a third of the money we need for TB research in the world. We need $2 billion per year. We only get 0.7 US dollars. TB is killing 1.5 million people a year, but we can't even find 2 billion. Think about this statistic. 40% of TB deaths are in BRICS countries, yet the BRICS countries contribute only 3.6% of the money for TB research. In the BRICS, our people are dying of TB, but our governments are not investing in TB research. This is a disgrace. We say to the governments of China, we say to President Xi Jinping, your people are dying of TB. Why are you not investing in TB research? We are saying to the government of India, we say to Prime Minister Narendra Modi, your people are dying of TB. Why are you not investing in TB research? We say to our government here in South Africa, we say to President Jacob Zuma, TB is killing your people. Why you do not invest money on research? Why do you invest less than 100 million per year on TB research? We can pay for Ngandla. We can pay for 1 billion for a presidential jet, but we can't find more than 100 million for TB research. Why? As we did at our march on Thursday, we demand again that all BRICS countries and Indonesia triple their investment in TB research over the next year. We can't just tinker and settle for incremental change while our brothers and sisters are dying. We demand a revolution in funding TB research. Friends and comrades, why does the world not invest on TB? Why is TB not a priority for heads of states? The answer is very simple. It is because TB mostly affects poor people. It is because we are poor. This is why the world can turn its back on us. Comrades, the lack of investment in TB is a political problem. It is political because at its essence, it is about governments not being held accountable for failing to respond on TB. We are not going to change if we accept business as usual. We can't win this battle if we don't make it a political battle. And to make it work as a political battle, we have to put poor people from affected communities at the center of our response. We will have to organize and mobilize, and then be willing to hold our governments to account. This week, the Union is talking about a new agenda. We appreciate the new agenda. It is a step in the right direction. But the thing we need most in TB is not a new agenda. We need a new attitude. We need to ask some tough questions of ourselves, of the Union. Why is the Union based in Paris and not in Delhi? Why is the next year's conference in Liverpool? Why at a moment where we need to draw more affected people in our response to the TB crisis? Why at such a moment take the conference away from where the people who are dying of TB are? Why there are no seats on the Union board allocated to civil society representatives? Friends and comrades, in the TB world, we too often beg for a place at the table. With that attitude, we will never defeat TB. 1 million people died of TB last year. Comrades, when 1 million people die, then we have a right to demand. In fact, when 1 million people die, we have a moral obligation to demand. So we demand that all high-burden countries be declared, or to declare TB a public health emergency. We demand that these countries implement all the new tools and policies we have at our disposal to fight TB. We demand that the BRICS countries triple their funding for TB research. If governments do not do these things, we must hold them accountable. We must fight this battle in the boardrooms. We must take it to the streets. And if we have to, we must take it to the courts. I appeal to all of you to join us in this work. 1 million deaths is an emergency. it is time we start acting as if it is an emergency. It is time not just for a new agenda, but for a new attitude. No more begging for crabs. From now on, we demand, and we demand that all of us, we have to fight TB and make sure that we save lives of people who are dying of TB. I thank you. Amandla, all power, all power. I thank you.
Thank you, Nelly, for your passion and your activism. The Union Conference is a time for all of us to come together as families, to talk, to share our ideas, to share our passion, to share our concerns, to share our science, and to share our advocacy. In the terms of one of my younger trainees, this week was awesome. It is also a moment to pause and recognize individuals who are making an outstanding contribution to TB and lung health with the presenting of the various union awards. I know that you probably noticed this week, rather than putting them all into the opening ceremony, they were spread out throughout the conference, and so please just let me take a moment to review them for you. This year, we awarded the Young Investigator Prize to Dr. Jason Andrews for his highly innovative work on the epidemiology of tuberculosis in high-burden settings. The Union Scientific Prize to Dr. Helen Cox, who was instrumental in the establishment of one of the first drug-resistant TB treatment programs in Central Asia and is involved in operational research in Kaalisha, a Cape Town township with a high burden of drug-resistant TB. The Carl Stieblo Public Health Prize went to Dr. Stephen Graham, who has made an enormous contribution to ensuring that tuberculosis in children has received the attention it deserves and improved the scientific basis for the treatment of childhood TB. The Princess Chichibu Global Memorial TB Award this morning was given to Professor Robert Gee, a professor in pediatrics and child health at Stellenbosch University and Tygerberg Children's Hospital, again for his work in pediatric TB. The Atsuka Union Young Innovator in TB Research Award was given this morning to Dr. Gregory Fox, who has been instrumental in the development of effective new policies in TB screening and prevention, most recently, I believe, in Vietnam. Professors Nulda Bayers, Professor Simone Schaff and Professor Don Innerson were made honorary members of the Union at the Assembly last night. And finally, Professor Dennis A. Mitchison received our highest honor, the Union Medal, for his lifelong commitment to tuberculosis and lung disease. And as Andrew Nunn noted in the award, Professor Mitchison has actually taken early retirement this year at the age of 96, but is still quite active. In reviewing these, I wanted to remind you, the membership, to encourage people to apply or to nominate others for the Union Awards in 2016. These awards are an extremely important and valued way for us to raise the awareness of the amazing work that's being done and to give individuals recognition that they rightly deserve. Details regarding how to apply for the 2016 awards will be on the Union website in the new year. I would now like to introduce another awesome person, Zalani Barnes, the chair of Imbizo.
Well, to be called awesome, that's great. Right, good afternoon, delegates. My name is Zolani Barnes, and I had the pleasure of chairing the very first community space within the union this year. So I'm going to start off by doing something that is totally prohibited from academic world and plagiarize. So, Jose, when he was doing his opening speech, he quoted Madiba, where he said, "It always seems impossible until it's done." It really did seem impossible until it was done. We did it. So today I'm here to reflect on the gathering that was. Remember in the opening ceremony, I introduced you to Imbizo as a gathering. So let's look at what happened during that gathering. So the first thing that we brought, the Cape Minstrel in all its splendor, as you can see over there, and basically showing the colorful Cape Town. So that was our call to bring you to the Imbizo. We then had Jose and Guy officially opening the community space. What we also seen, ladies and gentlemen, was a beautiful picture of Jane, Paula, and our comrade Anele holding hands as they were marching, demanding bigger investments in TB. And through tech, we saw over 1,500 people marching through the streets of Cape Town, saying we're dying of TB and that rich countries must cough up the money. Now, as a young man that also uses phrase like awesome, so social media is a big part of me. And of course, we had to integrate that within the space. And through TB Proof, we saw Prabod. And one thing that I noticed about Prabod, every time he takes a picture, he always fixes his hair. So he had a mask on, and he took a selfie, and I hope he uploaded that. And again, that was our way of raising awareness. So the space, ladies and gentlemen, was a buzz, as you can see. It was buzzing with excitement and information sharing with topics on work that is being done in correctional facilities and guides on being an activist. We had photo exhibition on silicosis. Now, as a way of trying to track the people that were in that space, we thought we needed to register everyone that was in that space. So, unfortunately, the communication was not clear within my team, so we've missed some of the delegates. So we've registered just over 400 people that were in that space, which we think is great. Because we were also offering services, so the few people that left knowing their HIV status, we had people that were screened for TB because we had a truck with chest x-ray that was doing the screening from TB HIV care there. We also had feel free to clap. I mean, this is awesome. I think the union showed support. We had Jose doing his rounds, as well as Prabod. And also we had activists like Blessy that was also chairing a session. We had Luchika in that space sharing a session. What was also awesome to see was Jane kicking a ball. And oh gosh, she can kick a ball. That was awesome to see. Now, ladies and gentlemen, it wasn't all too rosy. We had our challenges, we had our headaches. And I know we're passionate. So for some of you that I have offended, and for some of you that didn't have their sessions there, so I do apologize. We have taken the lessons and we will improve on that. So for those of you that have been to the space, you will be getting emails from us asking you to review the space. And for those of you that have not been to that space, shame on you. Now, ladies and gentlemen, it took me to go to the US, thanks to results, to meet this lovely lady. Now, it gives me great pleasure. She's known as the Princess of Africa. Yvonne Chaka Chaka has used a successful music career to raise awareness and challenges facing people across South Africa and Africa. Forbes magazine has ranked her one of the top 10 influential personalities on the continent. Ladies and gentlemen, it gives me great pleasure to introduce you, Yvonne Chaka Chaka.
Good evening, Is it not evening? I sing at night. Good afternoon, everyone. Thank you, Zolani. Thank you to the delegates. Thank you to everyone who is here. Well, the very first speaker, Anele Mtanam, where are you? Anele is not happy. And Dr. Carter's first word was, this week was awesome. It had to be awesome. But how can a week be awesome when somebody is not happy and somebody's not happy, somebody says the week was awesome. We need to work together. It is important. We, as South Africans, know how apartheid is. But after 21 years, we need to take ourselves out of those shackles. Health should not be for the rich. Health should not be for those who can afford. After 21 years of freedom in this country, not only South Africa, but the whole world, we need to be talking about health for all. I'm very happy, Dr. Carter, that you said the week was awesome. It had to be, because people like yourselves work day and night to want to make a world a better place. So it needs to be awesome. So whilst Anele is unhappy, we do have people who want to make a world a better place. So Anele, things are gonna be okay. Okay? Things are gonna be okay. Because we do have people like Dr. Carter and everyone in this room who is going to make things okay. But we need to talk to our governments. We need to hold them responsible. We need the political will. Ladies and gentlemen, today I stand here as a South African mother of 4 boys. I am very privileged that at least my children have had good health. Some of the children do not have good health. Some of the children are not as lucky as my children. But I'm standing here because some people have fought for me to be able to stand right in front of you. I have been given back my dignity by the people who fought for me, but we still have people who do not have food at home, who do not have housing, people who do not have good schooling, people who do not have good health, people who are dying of AIDS, people who are dying of TB, people who are dying of malaria in this day and age. Why is that? But I'm not going to despair. I have decided to be the voice of the voiceless. We are going to knock in every door and raise our voices and say it should be done for our children. And it's people like yourselves who are going to make this world a better place and make my job as an advocate easy. Because with the knowledge that you have learned here today, you are going to make sure that you go back to your constituencies and involve those very communities who need you. Today we've got scientists here, we've got professors, we've got researchers. But I'm sure you're not going to work in isolation. You're going to go back to your communities and work with them. We've got people here like Pumeza, where is she? Who suffered from TB and she couldn't hear. But today she can hear because people like yourselves made it sure that she gets cured, she gets medication. And I can say to you, thank you. I think we as South Africans, we are an angry nation, yes, including myself. Because I grew up in the apartheid regime, where as a young black girl, white young people would set dogs on me because I was not needed in town. I've got 3 dog bites in my body because as a young black girl, I was not wanted at this time of the day in town. And white boys would set their dogs on me and I could not report it to the police because I was black and what did I want in town? Yes, we were angry, but things have changed. I cannot go back there, but I can always remember that. But I see the light at the end of the tunnel with people like yourselves who want to change the world and make it a better place. So, ladies and gentlemen, this whole week has been indeed awesome. Zolani did say there were challenges and problems and bottlenecks, but we do learn from that, don't we? So if we all work together, we can break down the barriers. We can't have 1,500 people dying of TB when it is curable and preventable. Now we need to hold our governments responsible. And today, at the 46th Union of the Lung Conference, we still do not have the civil society on the board? That is not fair. We need to go back to that board meeting and make sure that we do have a seat for the civil society, ladies and gentlemen. So, the powers that be, do you promise me that we will have a seat for those people? Can I hear a yes?
You already have 2.
We do? Okay, please stand up and say that. Okay, Anele, we already have 2. Are you happy now? There's always a start, Anele, please. Look at me, Anele. Anele, look at me. There's always a start. We've got 2. That is progress. Are you not happy? We do have 2, don't we? You said. We have 2, so we're going to make it even better. Otherwise, I am not going to stop talking. We're going to talk until we get it right. I have chosen to be the voice of the voiceless. No one pays me for that. But I want to make this world a better place because if we don't, we are going to be judged by the next generation. And we need to do it for our children and for the betterment of this world. So we can't afford to have our children dying of TB, AIDS, and malaria when we have people like yourselves who work day and night to make this world a better place. So I can see the light at the end of the tunnel. So let's work together. Let's include our communities. Yes, we will have challenges. We will fight. We will disagree, but I'm sure we'll disagree to agree. Let's hold our governments responsible. Let's ask those countries who can give the funding to do so. But let's also get the countries who receive the funding to use it correctly. And the people as well who receive the money should not put that money in their pockets. Money should go to the people who need it the most. Ladies and gentlemen, I stand in front of you with so much humility and knowing that you are change agents and that everyone in this room is here because we all believe that we want to do good and we want to do it even better. So I believe when there's action, there will be results, and when there's results, we'll do good, and when we do good, our children will live a better life, and when we have better lives, we'll all be living very well, and we won't be crying to the Gates to give us money. Because shame, I think all of us, we get money from the Gates, don't we? And other donors. But we will make sure that the people who suffer the most, which are the poor, the poorest of the poor, live better. As I said, ladies and gentlemen, TB, AIDS, and malaria becomes diseases for the poor people. Why? Why should they be suffering? But I'm standing here knowing that with people like yourselves, there is a light at the end of the tunnel. Let's go back to our communities, let's go back to our constituencies and work with our people and impart that knowledge like we all did. I know most of you work with communities, and you're going to make my work as an advocate better, and we'll all work together. With that said, we can go back and say, still so many answers I don't know. I realize to question is how we grow. So I step out of the ordinary. I can feel my soul ascending. I'm on my way, can't stop me now. You can do the same. What have you done today to make you feel proud? Never too late to try. What have you done today to make you feel proud? What have you done today to make you feel proud? Let's do it for the sake of our children. We've chosen this path. Let no one turn us around.
We are so lucky to be able to hear your voice. Thank you. Thank you, Yvonne. Okay, so now this conference takes a huge amount of work and dedication to make it all happen, as you can imagine, and I would like to acknowledge the work of two groups of people in particular. The Coordinating Committee of Scientific Activities, of which I'm the chair, Subgroup 2, is made up of individuals who give hours of their time voluntarily. We are all volunteers to ensure that the very latest science is presented at the conference. I cannot thank this team of people enough for their opinions, ideas, solutions, and endless hours of their time, including until last night at 11 p.m. I'd also like to acknowledge the conference team who make sure that all the ideas come to life. And I suspect they're hiding. It is really hard to see, but okay. Their names are there, you can see. They work throughout the year on all aspects of the conference and deal with us as a group regularly and are seen all this week bringing everything together. In particular this year, I received many positive comments from you as the delegates about this year's registrations process. I would also just like to say, thank you to Zolani and the local organizing committee with the 10 NGOs that worked together to pull off the very first ever community space. So now we're going It was great. So now we're going to move on to the rapporteur session, to the science side of our scientific conference. It brings together highlights of the program from the conference and is presented by the members of the CCSA, our program secretaries. And I would like to invite them up to the stage. Now leading the rapporteur session is Carrie Tudor and Kevin Schwartzman. Carrie is a nurse, the Nurses and Allied Professionals Section Program Secretary, and she's a nurse consultant in South Africa and has extensive background in infection control and MDR and a tenured associate professor of medicine at McGill University in Montreal, Canada. Over to you, my friends.
Thank you. That's standing up. That's too big, that's too small. So good afternoon. Thank you for so many of you for staying till the very end. Thank you to Stacy for the introduction to the CCSA. We're a fun bunch of people, but we're going to try to give you a whirlwind tour of the conference, so hold on to your hats and seats. I just want to recognize the program secretaries for the different sections and subsections of the union, and they'll each come up and present for their appropriate section. So this year we reviewed over 2,000 abstracts that were submitted to the union. 1,014 were accepted, so about 48%. Thank you to all of the chairs and co-chairs of the different abstract sessions this week for giving us feedback. For the oral abstract sessions, we had a 77% response rate from the chairs for recommendations of abstracts to be included in this rapporteur session, so thank you very much. That's more than I think we were hoping for. So as I said, we're going to try to do this in 25 minutes, so hold on to your seats. And just as a thank you to the session chairs who provided feedback to us, your names are all here. We've double-checked and triple-checked. And I'm going to hand over now to Andrew Steenhoff of the Adult and Child Lung Health section.
Thanks, Carrie. So we had a number of amazing talks, presentations, posters in the Adult and Child Lung Health section. Singler and colleagues presented on lung sequelae post-successful TB treatment, as did Metcalf et al. Singler from the India National Program described that patients who'd been successfully treated for MDR-TB, 93% of them after 2 years of treatment had ongoing symptoms, 100% of them had radiological abnormalities, and 89% of them had abnormal lung function. Similar findings were presented, as I mentioned, by Metcalf and colleagues from Zimbabwe. And so the importance for us as a community is to recognize that this is happening. It's not unsuccessful treatment. These patients were successfully treated. But we need to be able to manage these problems and to try and improve the quality of life of these patients. By way of innovation, Chisunka and colleagues presented on how we can use satellites in lung health from Malawi. Traditionally, manual mapping methods have been used to assess prevalence surveys, and this is very heavy on resources and time. But this team used Google Earth Pro and mobile technology in a very innovative way to map, sample, collect, and manage respiratory data in Malawi. So terrific to see that innovation. What about chronic obstructive pulmonary disease? Well, Siddiqui and colleagues presented from Bangladesh, where they looked at 652 adult smokers who had previously normal lung function 2 years ago and now underwent spirometry or lung function testing. COPD, chronic obstructive pulmonary disease, had developed in 46 adult smokers here in Bangladesh, giving a 2-year cumulative incidence of 7.1% and an average annual incidence of COPD of 3.55%. And the comment of the team was that COPD incidence and new cases is very high in adult smokers in Bangladesh. And the importance is that, as in many low and middle income countries, COPD is a major public health problem in Bangladesh. What about childhood tuberculosis? Singh and colleagues presented a session talking about expediting the diagnosis of childhood TB in children in New Delhi. They had 261 children with confirmed TB, and they used immediate access to this rapid diagnostic that we're all aware of, Expert. 62 cases were actually detected by Expert that were smear negative, and they detected rifampicin resistance in 4 cases, which were culture negative. So in this setting, they use Expert to rapidly diagnose TB and to get children on treatment quickly. But they mentioned again, culture remains the gold standard, and we need new diagnostics for TB in children. Moving then to Lelo and colleagues, who described a study from the Democratic Republic of Congo, from Kinshasa. They had over 1,000 children who were diagnosed with TB in the hospital there. 809, or 80% of them, were tested for HIV, showing a gap of 20% who weren't tested. Of those 809, 55% were HIV infected. And this just reminds us as pediatricians, nurses, and others who are involved in child TB that we really need to do HIV testing in every single child who's diagnosed with TB. What about childhood multi-drug resistant TB? Well, Takova and colleagues presented this fascinating web survey of the clinical approach that doctors and nurses and other caregivers are using to approach the child who's an MDR contact, so someone in the home has got multi-drug resistant TB, across the countries highlighted in the diagram that you can see in Europe. I think an important statistic that this group brought out was that the proportion of new TB cases that are MDR, multi-drug resistant, in Europe is actually the highest in the world. So 15% of newly diagnosed cases are multi-drug resistant in Europe. This group looked at 25 countries. They got a survey back from 72 clinicians, and they showed a very wide spectrum of clinical practice around screening, preventative therapy, and follow-up in these child contacts. And they stressed the need for us as a community to develop better evidence and consensus guidelines around this relatively common problem. More on childhood multi-drug resistant TB was presented around the appropriate use of medicines in children who have multi-drug resistant TB. For so long, we've had data from from adult trials, and we don't know how children deal with these medications. And so there were pharmacokinetic studies presented by Garcia Prats around ofloxacin use in Cape Town. 85 children were using a dose of 20 per kilo. The actual concentration was relatively low, and they're going to move forward and simulate models and show us what dose to use. The good news, though, is that there was no effect of crushing tablets, which we often have to do in pediatrics, HIV, or malnutrition. And the outcomes in this group were good, and the medicine was safe and well tolerated, which is really important. Hafkin and colleagues presented data on delaminid, another new agent for multi-drug resistant TB, the first data on children or adolescents 12 to 17 years old who had 6 months of this treatment. And this is critical for us as pediatricians to know about. The medicines were well tolerated, plasma concentrations were similar to the ranges seen in adult trials, and now we're going to get data, hopefully next year, on children who are under the age of 5. Finally, childhood INH monoresistance is really important. INH resistance is the most common form of resistant TB disease globally. And in Karachi, Pakistan, Shakur reported some troubling results from a lab study where 329, 43% of children showed INH monoresistance. There's a significant upward linear trend in Karachi of more and more INH resistance, which is a major red flag for the future. And from Cape Town, we heard from Garcia Prats again, talking about the outcomes in 72 children with INH-resistant TB, which was rifampicin susceptible. The good news is that the clinical outcomes were good, but that 10 out of 37, so almost a third of patients, were still culture positive at 2 and more months. I'm going to hand over to my colleague in bacteriology and immunology, Stella.
Good afternoon, all of you. I'm going to present some of the highlights of the section of bacteriology and immunology. In 1882, when Robert Koch discovered the Mycobacteria tuberculosis, little did he know what we know now. Thank you. And since then, of course, we made tremendous progress, but still we have many questions, and I'm going to address some of the questions which were asked during this symposium. First of all, we want to improve the efficacy of the sample examination to detect TB, and then the question is, can we look at our sputum and see if we are more likely to find AFB if the sputum has a certain quality? And that was studied in an active case finding study in Vietnam, but there was no predictor at all, there was no relation. We know that the sputum examination in HIV patients is often problematic because it's often negative. This morning at the expert session, Grant Thorne presented a new LAMP lateral flow test using urine. And that is a quite promising test. Actually, it's more than promising because you already can use it. And it's especially for HIV patients with low CD4 count. You can do the test at the bedside, having some of the urine, and in 20 minutes you do have the result and you can start treatment. And in this study, he showed that this really very quick start of treatment has a significant effect of the survival rate of those patients. Of course, we have seen lots of sessions on GeneXpert, and next to the enthusiastic results, we also have heard words of concern, of cautiousness, because we know a test is always embedded in a context, and context matters, and then we also have to look at the impact. One of the things which has puzzled us always is the discordance of the GeneXpert results. It's GeneXpert positive, but then when you do a confirmative test, it's negative for LPA and the phenotypic DST. And it was a really nice presentation of Behane, who shed some light on that issue, why a GeneXpert test can be positive when it actually is just false positive. And she showed that it has maybe something to do with the hybridization pattern of the probes, the delay in hybridization, and that is a good explanation for that. So please look at those presentations when they are online. One of the things we always wanted to do is to detect latent tuberculosis. And we had hopes 10 years ago using those quantiferon tests, but that hope bashed quite soon after that. But now we have hope again, and early biomarkers were used to show, and they showed the association with progression of latent tuberculosis infection to clinical active disease. So maybe next year we can hear more about that. Another issue which puzzled us is the heterogeneity of the tuberculosis population in one host. And we found that out if we do the whole genome sequencing. And then the question is the genome stable or not stable? And actually it is difficult to find out the answer. But de Vos et al. Developed a method to more accurately detect heterogeneous variants. And then doing that, she showed interpatient evolution of isoniazid resistance. So that again contributes to our knowledge on the involvement of resistance. Very important resistance. We want to be able to detect resistance in old medicines which we are using, the pyrazinamide. And we have some concern because it was shown that it might be possible that that resistance is much more prevalent in the African population. And it's also known that the resistance testing is difficult, but if we don't do it, it might jeopardize the standardized MDR regimen. And of course, with our new drugs, we want to be able also to establish resistance and be very careful with that in the implementation. New drugs. We always want to have new drugs. But how to find new drugs better? There are some new methods to use it in the phase 2 TB treatment trials, and that would be an important step towards shorter regimens, because now the colonies can be phenotyped and the dynamics of the colonies can be quantified more. And then of course we have, but luckily we have exciting new work on developing next generation quinolones. Improving drug therapy. This is a new approach, and that comes from, can we strengthen the host response? And there was a study that showed that the antimicrobial capacity was strengthened to kill drug-tolerant bacilli, and thereby also enhancing the possibility to shorten TB treatment. So those are new possibilities and very important for future development. There was loads of other posters mentioned, but I end with one other study. That's totally, completely different study, but it shows that we should sometimes not look too far for a solution, and actually the solution can be found literally on our doorstep. And that was shown in a study in a crowded clinic, and they just made a simple intervention to put in a cough monitor, and the detection of patients of infectious TB symptoms increased significantly. So of course new tests and drugs are important, but also they must be embedded in a smart, organized health system. Thank you very much. civil society.
So good afternoon. My champion, this pair of shoes remind me of the journey I've gone through to be where I am today. These shoes helped me a lot during the times I was undergoing treatment and needed to take long treks from and to the health center for treatment and psychological support. I know they look uncomfortable, but what I see today is resilience and triumph. Not my words, but words of one Kevin, a former TB patient from Kenya, who, through the support of TB Photo Voice Project, has been empowered to share his story and to capture what he was going through when he was undergoing through treatment. This is one project which is very, very instrumental in making patients be able to come out, talk about their stories, share their experiences, and be able to use that experience to talk to other people about TB. And once they're able to talk, then they can use their experiences to support other patients, do contact tracing, and do defaulter tracing. So after they have been empowered, so the other question is, what next? And what next was evidenced in one of the abstracts that demonstrated that engagement of persons who have undergone the TB experience can be effective in case finding. And this was demonstrated in South Kivu province of Democratic Republic of Congo, where about 1,000 former TB patients were trained and engaged in doing contact tracing, defaulter tracing, and even community education. And in about 2 years, they had been able to mobilize about 570,000 people to go for TB screening. It has also been evident from this conference that community engagement is very instrumental in improving treatment success. This is a case study of it's a case study done in Southern Sudan, Juba, where community mobilizers or community volunteers are also mobilized. They were attached to one community-based organizations. They were trained for a period of time, again in community mobilization, contact tracing, and treatment support. And in a duration of 1 year, that is between January and December 2012, they had been able to increase the treatment success rate from 61% to 87%. And all this is only possible if it is being done in an environment where the human rights of these patients has been assured, and that there is also provision of social protection, as was demonstrated by in one abstract from India, where a project called Akshaya from India, they have formed district TB forums, and these forums work within those districts to ensure that patients' rights are observed, and they also provide other social support like nutrition and counseling. And again, this is not going to happen if we are not going to invest in TB, and it's also a message that national governments need to invest in TB. We need to invest so that we can live. Thank you.
So the HIV section had a number of exciting sessions, and I'm just going to try to give you a little bit of an overview of a number of different topics that were touched on. So screening and finding patients is always a big issue, and this study from Malawi compared routine passive case-finding programs with HIV TB screening and with a community-wide active case-finding program in Malawi. And while routine program case finding remained the dominant mode for detecting TB, they did notice a indirect health promotion benefit from the active case finding program, with an increase in almost a doubling of smear-positive notifications in the routine program over the study period. The symptom-based active case finding largely identified smear-positive, HIV-negative patients, and this may have very important implications for reducing transmission in communities. This study from South Africa looked to expand health services by including traditional health practitioners in the screening and referral of patients with HIV and TB symptoms. In this study, 800 traditional healers were trained to identify the symptoms of HIV and TB and to use this pictorial screening and referral sheet you see on the screen to refer patients to clinics. These traditional practitioners screened over 22,000 clients and referred over 800 to the local clinics, showing that the potential for these structures to support our health services. Of interest is that the health services were apparently not as good at reporting back to the traditional health practitioners on the outcomes of their patients' care, so clearly a lot of work around engagement still to be done. Dr. Yoon presented this abstract around using C-reactive protein to improve the efficiency of TB screening among patients who are new to the HIV/AIDS care program. And they showed that the CRP-based TB screening identified 5 times more patients who were eligible for IPT compared to the WHO symptom screen. And while not shown on this slide, they also showed that CRP-based intensive case-finding strategies detected a similar proportion of culture-confirmed TB cases as our current ICF strategies. Once we get patients in care, there are more challenges that await, and this study investigated incident TB among over 1,400 HIV-positive patients on ART for more than 3 months. And the incident TB rate detected in this group was over 2 cases per 100 person years. And you'll see here that the factors that were associated with developing TB were virological failure, which might suggest a further role for viral load testing beyond just monitoring treatment response, and also patients not being on IPT. So this study, performed in Zimbabwe, again, looked at the implementation of 6 months of INH prevention therapy among HIV positives in 7 pilot sites. And here you can see they reported high uptake and adherence to IPT, suggesting that, as Mandela said, it only seems impossible until it is done. This success was largely attributable to synchronized ART and IPT drug pickup visits. So this is a little different. In this study, patients, again, on ART for more than 3 months were randomized to an intervention arm that received, their cell phones were programmed to ring an alarm when ARVs were needed to be taken, along with the standard of care, and compared to a control arm that just received standard of care, and adherence was measured at 2 and at 4 months. And the arm with the program ringtone alarms showed improved short and medium-term adherence to ART, although this particular intervention did not, in fact, impact retention in care. Of course, all is not TB, and Grace McHugh reported in a session this morning on the substantial burden of disabling chronic lung symptoms in HIV-infected children and adolescents when compared to matched HIV-uninfected children. And then they followed up the study to look at HIV-infected patients on ART and ART-naive infected children, and showed that while children on ART had significantly lower complaints of respiratory symptoms, there was in fact no difference in lung function between the 2 groups, with no improvement in lung function noted despite many years in some cases on ART, suggesting that once chronic respiratory disease is established, the impact of ART is limited. And the investigators from this study motivated further studies looking at early ART and complementary therapeutic strategies for chronic lung disease.
There we go. So I'm going to talk about, with the nurses and allied health professionals in the patient pathway, and try to make this work with identifying patients, diagnosing patients, getting them on treatment and their treatment experiences, and then the training of healthcare workers. So this study from Tanzania looked at using training pharmacists and getting pharmacists to help refer patients to TB clinics, giving them a transfer card, an anonymous referral card given them to go to the clinic, and also sending them automated follow-up SMS reminders to them to go and report within 3 to 5 days. TB diagnosis was then done with either sputum microscopy, chest X-ray, or based on clinical findings. And they found that out of 627 presumptive TB patients that were identified through 6 referring pharmacies, 600 of them, or 95% of them, actually turned up to a health facility for further screening. And then in total, they identified 88 cases of TB in those patients. So giving us hope that that's one way that we may be able to engage with pharmacists and other types of healers. They also looked at traditional healers and referrals there, so that may be one approach to have going forward with patient-centered care. Another study from KwaZulu-Natal, which is on the other side of South Africa, they also looked at doing TB screening of hard-to-reach populations at a household level through using volunteer healthcare workers. These volunteer healthcare workers screened over 1,600 people in around 400 households. They were able to refer 350 patients or people who they presumed to have TB to PHCs for further screening, and 36 patients were started on treatment. They found that these volunteer caregivers were able to go in to reach people that are hard to reach, that they were seen as non-threatening, and that men particularly were more willing to talk to them and answer questions about their general health. So this is another opportunity to engage with more patients and get them to visit healthcare facilities. This study in Namibia by Kayla et al., they looked at compared ambulatory versus hospital-based treatment for MDR-TB under programmatic conditions. And many other studies have done this, but they further found that there's no significant difference between MDR-TB treatment success rates for patients that are treated ambulatory, so they're at home, able to stay at home with their families, may be able to go back to work sooner than being in a hospital for long periods of time. So they also found that this created lower costs on the health system. Families were able to be stable and to be able to go about their usual business. I know in other countries there are many single-family households, and so patients being in the hospital for long periods of time really disrupts the family system. And this further, they said, fostered trust in the healthcare system. Another study by Kelly et al., also in KZN in KwaZulu-Natal in South Africa, looked at the health-related quality of life for MDR-TB patients related to their adverse drug reactions during the intensive phase of MDR-TB treatment. They enrolled 121 MDR-TB patients and gave them interviews, one-on-one interviews, to ask them questions about the health-related quality of life, as well as adverse drug reactions that they were experiencing. As you can see here, 51% said that they didn't have enough food to eat, which is a big issue for many patients, and that 74% were co-infected with HIV. So what this graph, or this table shows, is that 119 or 98% of the patients had experienced at least one adverse drug reaction, and on average, patients had experienced about 8 to 9 adverse drug reactions per patient. And they did show that the higher number of adverse drug reactions that the patient had, the lower their health-related quality of life was. 43% had to have their regimen changed based on the adverse drug reactions to their treatment. And this graph, so part of the same study, shows the blue line is showing what the patients self-reported as their adverse drug reactions that they experienced on interview compared to what was documented in their medical chart by their provider. And you can see that there's great disparity between these figures. Particularly for me, which was most surprising, is depression, that it obviously, or potentially patients aren't either being asked about depression, and we know that suicide is a common risk factor for many patients on MDR-TB treatment, but great differences with loss of hearing, I think because many people see that as a very serious side effect, which it is, that there was much more correlation around loss of hearing than the other adverse drug reactions to MDR-TB treatment. So implications are that we as healthcare providers need to do a better job of asking the patient and keeping the patient at the center of care related to adverse drug effects, because that can affect overall adherence to treatment. So we can't have any of this patient pathway without having trained health professionals. So there were several studies this morning that were presented in a session on training of healthcare workers across the spectrum. So one was a study from Ghana on effective way to improve laboratory performance and external quality assurance by doing on-site training at the facilities for laboratory technicians to improve the quality of sputum smear and other testing. We had also a study from Laos that looked at the effectiveness of training on the quality assurance of chest x-rays. It wasn't on how to read chest x-rays, but how to better perform them and make sure that the machines and everything is operating correctly to give the best quality chest radiograph possible. We heard from Peru where they've done a distant learning pilot course for frontline healthcare workers on the updated and new Peruvian National TB Program guidelines. And they found that 70% doing this distant learning on 6 hours per week on average on their healthcare workers' time outside of the workforce, that 70% completed and they had very high rates of post-test knowledge scores. A study from here in Cape Town or outside Cape Town looked at evaluating different models of training for healthcare workers, especially at the primary healthcare center level for childhood TB, which was interesting because it compared different modalities, which is not always done. And then we heard from Russia where the interaction between nurses and doctors in caring for patients, again, bringing it back to patient-centered care, if there's not good relationships between healthcare providers or a lack of confidence working between nurses and doctors or other parts of the healthcare team, that the patients may suffer, and so that we really need as healthcare providers, all of us, lab, radiography, nurses, doctors, need to work together as a team. And the group suggested having more integrated training, not just training doctors alone or not just training nurses alone, but doing integrated healthcare training to improve patient care. And I will now hand over to Omara Dogar from Tobacco.
Thanks, Kerry. There were so many exciting symposiums and working group sessions for tobacco control this year, but due to time limitations, I'll just go through the highlights of our oral and poster abstracts that were presented during the conference. So this is a study about development and feasibility and fidelity testing of a bespoke behavioral support intervention for smokeless tobacco cessation in South Asians. Why South Asians? Because about 3/4 of all smokeless tobacco users in the world are South Asians by origin. And the products that they use are particularly highly addictive and hazardous to health. And evidence on effective cessation interventions for smokeless tobacco products is lacking, especially in this population. So this intervention was developed particularly focusing South Asians, but the development process was quite comprehensive. There was a thorough literature search conducted to identify the determinants of why South Asians use these products and continue using them, why they take them up in the first place. And the literature informed these determinants that was then linked to behavior change theories and techniques that actually work on these determinants. All of this process went through several expert panel consensus sessions, which were done through modified nominal techniques. And because this was a large study, not in terms of sample, but in terms of time investment, it was an 18-month study, it gave the opportunity to develop fidelity measures using the intervention theory during the process of intervention development. In addition, the feasibility, the barriers and facilitators of delivering this intervention, and also the acceptability by the participants, how they received the intervention, were conducted through semi-structured interviews. At the end of the feasibility study, all of this information was fed back and the intervention was refined. The feasibility study, after the intervention was developed, it was conducted in Pakistan and in the UK, in local NHS sites. There were 32 participants that were recruited, 16 in the UK and 16 in Pakistan. The questionnaire that was administered, the information that was collected was on demographic characteristics, their smokeless tobacco use, history, the type of products they use, and there were several dependency scales that were assessed during this process, which works best in them. Their cotinine levels were also tested at baseline and at 6 months post-intervention. So, I'll just go to the findings. We found that negative emotive images had an impact, and furthermore, knowledge about the consequences of using smokeless tobacco products and the consequences of quitting, and the management strategies to enable people to manage their triggers and withdrawals were particularly acceptable by the people, and they had an impact. It was also found that using grading scales for assessment of motivation and readiness to quit and nicotine dependency scales were particularly challenging in this population. Also, reduction approach was favored over abrupt cessation by the participants. The study provides a methodological basis for measuring fidelity, but it is also a way in which behavior change science has been transformed from the Western culture and adapted to the Eastern populations. Further, this intervention is now ready for effectiveness testing, and there is a digital application also available that is publicly available for everyone. The other abstract was an oral abstract, and this is about illicit white cigarettes, which are basically manufactured legally. Okay. They are manufactured legally with a large share of the production being sold illegally without all taxes paid, usually outside the country where they're produced. For example, Jingling, I've just shown the photo of it. This is a famous white cigarette, which is found in EU region. What this study did was it searched academic articles, newsletters, other documents from the government's newspapers, even the tobacco industry. And they found 82 cheap white brands that were manufactured by 53 companies. And 1/3 of the production facilities of these companies were in the free zones of Russia, Cyprus, and UAE. Free zones means the legislation is quite weak there. The TPAC SS database was generated by the Johns Hopkins School of Public Health, Institute for Global Tobacco Control. In 2013, they did a systematic purchase of cigarette packs in 14 low and middle income countries, and this contains information on 37 cheap white brands. In conclusion, it is a misbelief that cheap whites are generally sold at half the price of domestic duty-paid cigarettes. However, the study found that illicit whites are cheaper, but not everywhere, and sometimes the local taxed products are cheaper than the untaxed smuggled products. I will finish by saying that tobacco control has come a long way, not just in the Union, but also in other public health forums in the world, represented by the change agents, as Chaka mentioned. But this is not an individual effort, and tobacco affects all the conditions that are addressed by the Union. And my plea to everyone in this room today is to please join hands in this effort. We really need everyone's support. As I've said, we have to go a long way yet. Thank you.
Okay, so TB has a very large number of abstracts and presentations, and I'm going to summarize a few of them extremely quickly, and I would encourage you, if you would like further information about any of these studies, to look up the abstracts. So a couple, first of all, about active case finding. An interesting study looked at 4 districts in Cambodia where mobile teams, after volunteer symptom screening, did chest x-rays and expert, and this effort targeted largely persons over 55 living in rural communities. They visited a total of 76 health facilities. Over 9,000 individuals had chest radiographic screening, and of those, nearly 20% had expert testing, and of those, just under 20% had positive results. And this led to a huge increase in microbiologically based notifications for patients of all ages, particularly those in the older age category, which had been targeted. A second study looked specifically at persons living with HIV in Vietnam who are not yet on antiretroviral therapy. In this case, again, a TB symptom screen was used, followed by a diagnostic and treatment algorithm, and these were added to routine clinical encounters every 3 months over a 1-year follow-up period. And although there are a number of very interesting results from this study, I'm focusing on mortality, and as you can see, there was an evident mortality benefit for those individuals who underwent these regular screenings. One study that I'll highlight related to diagnostics, presented yesterday at the Union CDC Late Breaker session. This was a pragmatic RCT which examined the impact of the urine lipoaberinomannan, or LAM strip test, and involved adults admitted to hospital with suspected HIV/TB in South Africa, Tanzania, Zambia, and Zimbabwe. In this study, the primary outcome was mortality, and in fact, the addition of this diagnostic test reduced overall hazards of death by 18%. We've heard earlier about INH monoresistance. This is another study addressing that issue from South Africa, from Durban, where there was a retrospective comparison of approximately 500 INH monoresistant cases with over 16,000 fully drug-susceptible cases. Of note in this context, new cases who were later found to be INH monoresistant, in retrospect, underwent the standard regimen, and when they were retreated, they underwent a modified retreatment, standardized retreatment regimen. And what you can see is among this particular analysis accounts for HIV status, and only about 6,000 patients had their HIV status known, which is why the number is smaller. But nonetheless, you can see a clear increase in the risk of death for those who are INH monoresistant, as well as an increase in the risk of both death and failure combined. There were a number of studies looking at TB and diabetes. One of these involved participants in a community-based health screening study out of Taipei, Taiwan. In this particular case, the results of the health screening were linked with the National Health Insurance Database. And in this case, in this study, the diagnosis of diabetes reflected either drugs prescribed in that database or alternatively a high fasting glucose level during that survey. What is interesting is that they stratified patients into those with good or poor diabetes control, with poor control defined as a level over 130 milligrams per ml. And in fact, although not surprisingly, diabetes overall was associated with the occurrence of tuberculosis with an odds ratio of about 1.6. In fact, this split in such a way that essentially all the increased risk was attributable to those with poor glycemic control. Yesterday at the Late Breaker session, we had a very interesting basic science presentation about TB and e-cigarettes. This is focusing on monocytes, important immune effector cells, which were exposed to cigarette smoke exhaust, electronic cigarette smoke exhaust, e-liquid, in other words, what people put in the vape devices, or pure nicotine. And these monocytes were infected with BCG, H37RV, or CDC 1551, and what was measured was TNF-alpha, again a key cytokine, in cell culture supernatant. And in fact, what was found was that, in fact, for all of these, including the e-cigarette materials, there was a significant reduction in TNF-alpha production. Of course, this is a long way from clinical practice, but it tells us that e-cigarette smoking is unlikely to be safe with respect to the occurrence of TB. There were a couple of studies, among many, which looked at LTBI in low-incidence countries. One of these took place in U.S. federal prisons, involving primarily men, median age 36, of whom 20% were known contacts of persons with pulmonary TB. And what was of note was this group was given the 12-week isoniazid rifapentine regimen, and of this group, 92% completed treatment, as compared with a historical figure of approximately 55% for isoniazid in the same context. A second study looking at another group of particular interest in low-incidence countries looked at healthcare workers. This was a modeling study using a Markov model and a 10-year time horizon. And essentially what was examined was different serial screening strategies after accounting for the major sources of variability known to affect serial quantiferon results. Outcomes were projected looking at different testing algorithms and different cutoffs for defining a positive conversion. And a key result here was that although nearly a third of workers would be predicted to test positive after 10 years, the majority of these were in fact false positive test results. And this gives us pause when we think about the application of this type of test for serial testing of healthcare workers in low incidence settings. We had a couple of, or many presentations, these are a couple of highlights looking at the costs of TB care. This one from South Africa used data collected in 2013 and looked at early post-diagnostic costs for patients living with TB and or HIV and their households. They looked at both direct and indirect costs, with indirect costs defined as reported income lost. And in fact, what they found was that, not surprisingly, TB-HIV was the most expensive, costs an estimated mean US dollar figure of $85. This was, more than half of this was attributable to income loss. And in fact, in many cases, the mean costs were catastrophic for these households, and again, highest for TB-HIV. Social protection and cash transfers, another topic of interest. This particular randomized cluster study was reported yesterday at the late breaker session, looking at households in Lima, Peru, 300 plus of which were randomized to either standard care or standard care plus a socioeconomic intervention, which consisted of household visits, community meetings, and conditional cash transfers. And what we see here, and again, there were a number of results presented, but interestingly, those households where the intervention was given, the contacts were more likely to complete preventive therapy than in those households where that was not the case. And a very interesting aspect of this was that participants were asked to rank the various elements of this social protection intervention, and in fact, they ranked the cash transfers as the least important, and the other social support activities as considerably more important. Just to wrap up, I think it's important, we've heard a number of discussions today around this theme, and I think it's good to wind up with this. We have to remember that although much of what I've presented is medical, there's an important human aspect. And so a couple of posters that remind us of this. One reporting adolescents' experience of MDR-TB and their participation in clinical research, focusing on challenge of stigmatization, body image, and the particular support needs for this age group. And there was a very interesting poster looking at the ethics of how we approach risks and benefits when potentially offering new TB drugs, either in a trial or in a program setting, and that it's important we remember broader social context and dynamics. Remember that these are what impose the risks on patients who are deciding about complex and potentially fatal disease, as well as potentially fatal treatment, and there are other principles other than simply risks and benefit that need to be considered. Thank you.
At the zoonotic subsection, we got an update on estimates of zoonotic TB In the US, for example, they document that it accounts for between 1.4 and 1.6% of the TB burden there, and it typically affects female Hispanics who present normally with extrapulmonary TB. And the map down there shows the areas where the cases were identified. And when we compare to what happens across the pond in the UK, the disease actually occurs in UK-born senior citizens, but most of them would have had a history of contact with animals. And that's a map that shows where all the cases were encountered. The problem seems to be much bigger in India, where a study that was done shows that nearly 50% of the positive cases actually were M. bovis, and they are isolated more M. bovis in cerebrospinal fluid. And when they tried to actually decipher where the source of transmission would be, we could see that most of the milk actually had M. bovis, not only M. bovis, but also MTB. In Nigeria, a survey that was done at the abattoir level, you see that there's a huge proportion of cattle that go through the abattoirs that have bovine TB. They also looked in the people who work with the animals in the abattoir. Although they didn't find M. bovis in slaughtermen, they found that some of them had MTB. Now, one of the challenges in understanding how big the problem is the lack of cheap, robust, and point-of-care diagnostics that can distinguish between M. bovis and MTB. And there's a group at Queen's University, Belfast, with funding from Gates, who are actually modifying a lateral flow device that was originally developed for diagnosing M. bovis in badgers, that is being developed actually to diagnose zoonotic TB in human. And this actually, with funding, will be further modified to be able to detect both M. bovis and MTB in sputum. Now, finally, in the spirit of a paradigm shift, most of the vaccines that we have today are designed to provide sterilization immunity. And maybe we need to think outside the box and develop vaccines that actually block transmission. And the ferret actually has been put forward as a model for this sort of work. Now, we need to understand how the transmission occurs, and among all the advantages that ferrets have, actually they do cough and sneeze just like we do, and they are also as social as we are, which is a recipe for TB transmission. Now, the studies that have been done so far show actually that these ferrets are a good model for these transmission studies. And on a ferret note, I'd like to thank you for attending the 46th Lung conference on the 46th World Conference on Lung Health, and hopefully we'll see you in Liverpool next year. Thank you very much.
Okay, trying to make this quick so we can get out and have some food. Okay, now I'm going to welcome Jose Castro, Executive Director of the Union, to the stage. After thanking you guys so very much, that was brilliant. It's lovely. I didn't see hardly any sessions during the conference, and it was amazing to get this snapshot.
Thank you, Stacy, and thank you, ladies and gentlemen, for being here and also for staying through the end of the ceremony. Earlier this morning I spoke to a reverend from South Africa who spoke so eloquently about the interactions that he had with researchers in his community, but also what it meant to him to participate and attend this conference. And I was really moved by his presentation yesterday, but also by a comment that he said, this was really wonderful for him to come and speak before this audience of international experts that have from over 130 countries that have come to South Africa. This is the Union. This is the spirit of the Union. The Union was founded in 1920 in Paris with a promise and a dream. A promise that one day we will rid the world of tuberculosis. They didn't say which day, but they said one day we will rid the world of tuberculosis. And that was a dream. I always get these two confused, but the dream was that one day we will rid the world of tuberculosis. And the promise was to bring the world together to fight tuberculosis. And all the distances traveled since 1920 to today have been traveled trying to perfect that promise and that dream. Imagine the outrageous optimism of the founders of this organization in 1920, at a time when there were no medicines available to fight tuberculosis, to dream of eliminating tuberculosis from the world. A few years later, in 1930, in the conference that was held in Oslo, the members of the Union, it was an important conference, because the members of the Union there approved or decided how the distribution of the BCG, the first vaccine for children, will occur at a time when it was very difficult to move the logistics and distribution of a medicine around the world. We didn't have the modern airplanes or ships to get them. So when I look at the Union, I marvel how this organization has been faithful to that promise and to that dream of its founders. Today, the Union is in the battlefields of public health. It is in New Delhi, and it is in 300 districts in India that are difficult to reach by the health services. It is in Kampala, and it is in Kinshasa, and it is also in Harare. And it is in 146 countries around the world where each of you, the members of the Union, every day work hard to find better solutions, to find tools to fight these epidemics, this relentless epidemic that we will one day get rid of. But to end the status quo that we heard from our previous speakers prevent us from reaching those goals, we must change. And after speaking to people in this conference, after hearing the presentations, I can see that it is changing. We heard groundbreaking new science presented this week. People living with MDR-TB are being effectively treated with a 9-month treatment regime. Not 24 months, 9 months. And we are pursuing even better regimes, including a 9-month regime that requires 0 injections, as well as a 6-month regime of MDR-TB, a 6-month regime. We heard the announcement of the world's first TB medicines designed specifically for children. We met with researchers and some of the adolescent participants involved in a new vaccine trial taking place here in Cape Town. We saw how TB is spreading rapidly within prisons, and we learned about a model in Tanzania that is stopping it. We learned that zoonotic forms of TB are passing from animals to people in large numbers, creating unique challenges that we can no longer ignore. And at this conference, doctors, nurses, advocates, survivors discuss new models that address TB, HIV, tobacco use, and diabetes in the same clinic visit. We understand that we need an interrelated approach against TB, HIV, and lung disease and non-communicable diseases. And we explore the promises of sustainable funding. We know that tobacco taxation is a powerful tool for reducing tobacco use. Earlier today, we saw how it can support other neglected areas of public health. Governments must increase tobacco taxes to strengthen financing for health care, especially care that serves people living in poverty. Better care, bolder policies, bigger investments. These are the building blocks of a new agenda, and it is being built by all of us working together. Members, advocates, patients, the union is committed to supporting you in every way, to build knowledge, to share it with others, to take action together. We will continue to support each other to implement this new agenda. And finally, I want to thank you all for the time and for traveling this far to participate and be part of the 46th World Lung Health Conference. And before I step down, I would like to call my colleague Bertie Squires, who will tell you a little bit about Liverpool in the next conference. Thank you very much.
Thank you very much, Jose. For me, one of the defining elements of this conference has been this look forward as a new agenda. And one key thing to bear in mind when we try to answer that very valid question, why Liverpool next year, is we're now in the era of the Sustainable Development Goals, and a key thing that the Sustainable Development Goals tell us is that the problem of poverty is a global problem. Liverpool has poor populations, the UK has poor populations. This cancerous problem of poverty is one that we are collectively responsible for wherever we are. And I would make that a rallying call to you for at least part of the reason why you need to come to Liverpool. Now, on a much happier note, Liverpool is a multicultural port city with a rich heritage, and it has been at the forefront of pioneering issues and interventions in health, which are at the heart of the Union's mission. And finally, it has strong linkages to international initiatives that will enhance our ability to deliver on the Union's vision of health solutions for the poor. So just to give you some examples under each of those three key points, this rich cultural heritage in Liverpool boasts that it has the Europe's oldest Chinatown. It has the largest collection of Grade 1 listed historical buildings outside of London. One of them in particular is the Albert Dock, which you see there in the bottom of the picture. Built in 1848, it's the world's first warehousing system that it was entirely built of non-combustible materials. It's recently been refurbished and rebuilt, so it houses a number of very interesting galleries, including the Tate Art Gallery, and it's right next to the conference arena and the conference convention center and arena where we will be. In 1907, our iconic Liver building was built, and it was the first large-scale building to include metal, which then paved the way for all the skyscrapers of the world. That's Europe's first skyscraper, 1907. And finally, this was a city that is such a cradle of creation. It gave us the Beatles and two world-famous football clubs, one of which I'm representing here because I support it. So a quick run through pioneering events in the world of public health. In 1847, Dr. William Duncan was the world's first medical officer of health. In 1898, the world's first institute devoted entirely to the study and solutions of tropical medicine was established in Liverpool. And in 1959, it was the first city to X-ray all of its inhabitants in the campaign against tuberculosis. And in 1996, it was one of the first cities in Europe to recognize distinctly the association between health inequalities and poverty through the City Health Plan. So when it comes to linkage to international issues, national issues, the city has active engagement with civil society and affected communities in the UK through HIV, lung health and TB patient support organisations. London has the highest rates of tuberculosis in Western Europe, a major scandal. Parts of London have higher rates of tuberculosis than Iraq and Rwanda. Nick Herbert, a British MP, chairs the Parliamentarian Caucus, and that, I think, will give us a voice with global politicians from the Liverpool platform. Just in the last year, England signed off a new public health strategy, and over the last 2 years it has developed new guidelines through the National Institutes for Health and Care Excellence, which for the first time will combine both clinical and public health elements. And a key feature of that process over 2 years was active engagement with affected members of the communities. I and others worked with three members of the affected community, all survivors of tuberculosis, who came from very different walks of life and were directly involved in formulating those guidelines, which are not yet issued but due out next week. And finally, our Chief Medical Officer, Sally Davis, has been a really strong voice in raising the importance of antimicrobial drug resistance around the world, which brings me to our theme, I hope you'll see, which is confronting resistance. So this will be looking at both fundamentals and innovations, and it addresses a number of critical areas for discussion. The growing problem of resistance to TB drugs, and it also reflects on our global tobacco control work, where we need to coordinate more than ever to resist the tobacco industry and introduce those policies needed to denormalize and reduce tobacco use. So online submissions for symposia, workshops, postgraduate courses will begin in mid-December. It's right upon us. And we welcome your ideas for sessions across the board: TB, HIV, adult, child lung health, tobacco control, civil society engagement, and we really encourage those submissions. We only have 10 months in which to get ourselves together on this. So I urge you to bring your ideas and your energy, please, to Liverpool and your data. Without you and your input, the World Lung Health Conference will not function. Really looking forward to seeing you in Liverpool next year.
Thank you, Bertie. So over 20 years ago, I went to my first Union Regional Conference, and I knew then I had found my family. And I hope that in the halls this week, you found your family as well. But of my family, I need to take one last thank you and again highlight the leadership and an incredible organization of our chair of our CCSA, Stacy Stender. As a family nurse practitioner, Stacy is the first nurse to act as a scientific chair. I should have realized that, because I've always said at home that my TB clinic was really run by the nurses, and I wondered sometimes why I was there. So, again, thank you to all of the members of the union. You are the individuals who make us what we are, who do the work, who set us in the right direction, and we just want to appreciate you and acknowledge you. Thank you for being my family, and let me invite the family to the reception outside. This brings to a close the 46th Union World Conference on Lung Health. Thank you very much.